Okay, so now we announce with the second session, and Dr. Maher Asaad will give a talk on the role of erythropoietin in the management of anemia in CKD. Dr. Maher.
Colleagues and friends. Also, I want to thank Janssen for their invitation. Our talk today will be about erythropoietin. Erythropoietin is an innovation, but innovations usually are preceded by observations and research. Since the discovery of the gravity law by Isaac Newton, he made a simple observation of a falling apple on his head from the tree. Since then, medicine and science in general have been based on observations of scientists and doctors on patients. In 1983, the Swiss biologist Friedrich Mischer noticed that residents of an Alp resort and sanatorium had increasing hemoglobin levels. He wondered why, and finally he attributed this finding to hypoxia of high altitudes. "84 years later, the American scientist Eugene Goldwasser, he could succeed in isolating the human protein erythropoietin EPO. That started to be commercially available about 12 years later. Physiology of the renal interstitium. The renal interstitium is defined as the intertubular space of the kidney. It is bounded on all sides by tubular and vascular basement membranes and is filled with cells, extracellular matrix, and interstitial fluids. The intertubular interstitium harbors cells, dendritic cells, macrophages, lymphocytes, lymphatic endothelial cells, and various types of fibroblasts. This is a diagram to show the interstitium in its various cells, the interstitial compartment containing non-hormone producing fibroblasts, microvessels, perivascular cells, renin-producing perivascular cells, juxtaglomerular cells, and erythropoietin-producing fibroblasts. The renal fibroblasts. The primary function of renal fibroblasts is to provide structural support to nephrons through deposition of extracellular matrix. In addition, fibroblasts play an important role in maintaining vascular integrity in close association with vessels. Renal fibroblasts are best known for their role in progression of interstitial fibrosis in progressive chronic kidney disease because they are principal producers of extracellular matrix. Finally, fibroblasts have been identified as sources of erythropoietin and renin in the kidney. Erythropoietin is an indispensable glycoprotein hormone that is produced by type 2 interstitial fibroblasts and controls hematopoiesis through promotion of survival, proliferation, and differentiation of erythroid progenitors. In adults, about 90% of EPO is produced by renal interstitial fibroblasts, whereas 10% is produced by extrarenal sources, primarily the liver. This is a simple figure to show the process of erythropoiesis on the left side of the slide shows the EPO-producing cell in the middle, the bloodstream, and on the right-hand side, the bone marrow cell. Simply, the EPO gene in the EPO-producing cell is upregulated and stimulated by many factors, the most important of which is the hypoxia-inducing factor 1 alpha. The HIF protein is simply upregulated and downregulated. What upregulates the HIF protein and what downregulates? The most important stimulus for HIF upregulation is the presence of local hypoxia. Usually the fibroblasts are situated around the peritubular capillaries of the kidney. So it senses the reduction of oxygen carried on the heme molecules. The heme molecule is a molecule that resembles a pyramid. When it is oxygenated, we can imagine the presence of an open pyramid. And when it is deoxygenated, it resembles a closed pyramid. The closed heme molecule complex is the major stimulus for the type 2 interstitial fibroblasts to secrete erythropoietin. When erythropoietin is secreted, it circulates in blood and targets its target cells in the bone marrow, sticking to the erythropoietin receptor on the bone marrow cells and producing red blood cells. Decreased oxygen tension, as we said, is the principal stimulus for renal erythropoietin excretion. EPO deficiency is most important cause of anemia in chronic kidney disease patients. Physiologic plasma erythropoietin levels in blood is relatively low at around 100 picogram per ml, whereas under hypoxic stress associated with severe anemia, they can reach 100,000 picogram per ml. Erythropoietin levels are better preserved in glomerular diseases than in interstitial diseases, suggesting that impaired EPO production is a direct consequence of interstitial disease. However, polycystic kidney is an exception because it is often associated with increased EPO production and may be up to polycythemia due to the aberrant hypoxia-inducer factor 1 alpha accumulation around the cysts due to local hypoxia. There are causes that make the effect of erythropoietin less, or what we call erythropoietin resistance or refractoriness, which is very important in treating anemic patients. The first factor is iron deficiency. The second is chronic inflammation. The third, nutritional status. The fourth is secondary hyperparathyroidism and other causes. When we come to talk about iron deficiency, it is either absolute iron deficiency with depleted iron stores or relative or functional deficiency, which prevents the use of available iron stores. The consensus is that iron therapy can increase hemoglobin level, postpone the need for erythropoiesis-stimulating agents therapy, and optimize the response to treatment. Guidelines recommend that oral iron will generally be sufficient to attain hemoglobin within targets in erythropoiesis-stimulating agent-treated CKD patients, especially in the early CKD stages, not in the late ones, of course. Not yet on a regular hemodialysis, and those on peritoneal dialysis. However, in patients with resistance to erythropoietin-stimulating agents therapy on oral iron or intolerant to oral iron, a therapeutic trial of IV iron seems reasonable. In contrast, most hemodialysis patients require intravenous iron. The second important cause is the presence of chronic inflammation. Most chronic kidney disease patients present a chronic inflammatory state of increased levels of inflammatory markers such as C-reactive protein, interleukin-1, interleukin-6, interferon gamma, and tumor necrosis factor alpha, and increasing prevalence is associated with decreased renal function. Uremic syndrome, heart failure, persistent infections, biocompatibility of the dialysis membrane, use of catheters, accumulation of advanced glycation end products, and progressive decline of GFR may contribute to inflammation in chronic kidney disease with consequent cytokine production. The presence of high circulating levels of interferon gamma or tumor necrosis factor alpha causes the need for higher amounts of erythropoietin. In the hemodialysis patients, inflammation has been associated with erythropoietin resistance, mainly because the inflammatory state decreases the bone marrow response to erythropoietin-stimulating agents and/or inducing hemolysis. The hypoxia-inducible factor, prolyl hydroxylase inhibitors, licensed for use in von Hippel-Lindau syndrome, renal cell carcinoma, pancreatic neuroendocrine tumors. Those researches started mainly in China and Japan, but recently it has been tried in cases of refractory renal failure anemia due to inflammation. This is also a diagram to compare the normoxic conditions and the hypoxic conditions in the presence of hypoxia-inducible factor prolyl hydroxylase inhibitors. The chronic kidney disease patients are at substantial risk of malnutrition, causing nutritional deficiencies characterized by loss of protein energies. Their nutritional status is affected by the general decrease in nutrient intake, dietary restrictions, intestinal malabsorption, inflammatory state, metabolic acidosis, and dialysate losses. These situations increase the risk of micronutrient deficiencies such as folic acid, vitamin B12, and iron. Nutritional factors is associated with erythropoietin resistance in hemodialysis patients due to malnutrition inflammation status. Another important factor of erythropoietin resistance is secondary hyperparathyroidism. Secondary hyperparathyroidism starts early in the course of the disease, and it is sometimes forgotten by clinicians to look for, and treat early in the course of chronic kidney disease. It starts early and worsens with disease progression. In the late stages of chronic kidney disease, PTH synthesis and secretion is continuously stimulating, causing secondary hyperparathyroidism. Although chronic kidney disease, mineral bone disease, is the most widely recognized consequence of hyperparathyroidism, consistent evidence shows that PTH and fibroblast growth factor 23 have adverse effects on extraskeletal tissues, including the development of anemia. This causes bone marrow fibrosis with consequent increase in EPO requirements. In addition to this pathway, PTH is identified as a uremic toxin that suppresses endogenous EPO production, inhibits bone marrow erythroid progenitors, and decreases red cell survival. High levels of fibroblast growth factor 23 cause inflammation that adds to anemia and EPO resistance. Hyperparathyroidism control should be attempted to treat erythropoietin resistance. Several options are available, including medical treatment with vitamin D receptor activators, cinacalcet hydrochloride, and up to parathyroidectomy. Other important factors that contribute or might contribute to ESA refractoriness is the medications that work on the renin-angiotensin system, the angiotensin converting enzyme inhibitors and the angiotensin receptor blockers. They can decrease the hematopoietic response to ESA. Renin-angiotensin system inhibition decreases erythropoiesis, and ACE inhibition can lead to high levels of negative erythropoiesis regulation. Angiotensin II mainly is responsible for the presence of upregulation or high levels of hypoxia-inducible factors. So when you inhibit this system or you block it either by ACEs or ARBs, you reduce the level of angiotensin II, so you make less available hypoxia-inducible factor levels in our circulation. Currently, ACE gene polymorphism are known to largely influence ACE serum activity. Thus, some patients are more susceptible to ESA resistance when using ACE or ARB inhibitors. The presence of anti-erythropoietin antibodies can cause pure red cell aplasia. It's a rare condition as a cause of erythropoietin resistance, usually difficult to treat. Some trials with corticosteroids, sometimes other immunosuppressive agents such as azathioprine, cyclophosphamide, can be tried. If all this fail, we will definitely need blood transfusion repeatedly. It should be suspected in an individual who has previously responded to erythropoietin if the hemoglobin declines by more than 2 grams per deciliter per month. Also, inadequate dialysis can cause erythropoietin-stimulating agent resistance. So the dialysis adequacy and efficiency is a very important issue, especially in our country and other developing countries. We should be insisting on performing 3 dialysis sessions per week, regularly 4 hours, not less than that, using adequate dialyzers in relation to condition and body weight of the patient. There are other less important adjuvant ESA therapies, such as L-carnitine ascorbic acid, vitamin B12, folic acid, statins, and zinc. They show some positive results. However, the current guidelines do not recommend their routine use unless there is a documented deficiency. This is a simplified algorithm for how to manage the resistance or the hyporesponsiveness to ESA therapy, measuring the reticulocytic count. If high, we should be looking for blood loss or hemolysis. We should be investigating such a condition by doing endoscopies, upper GI, colonoscopy, excluding factors that can be associated with hemolysis, such as Coombs test, LDH, and bilirubin. And we also should be checking the compliance of the patient on taking his erythropoietin. Sometimes the subcutaneous injection is painful and can cause some local burning in some patients. Before embarking on looking for other important factors of resistance, we should be checking that the patient is regularly taking his ESA therapy. Iron deficiency, we should be looking for, of course, the serum iron, the ferritin level, the transferrin saturation, the total iron binding capacity. We also should exclude the presence of infection, inflammation, or under dialysis, as we previously said. Markers of inflammation commonly used and looked for, the C-reactive protein, the dialysis adequacy, biurea kinetics, and KT over V. Also, we should be checking vitamin deficiencies such as vitamin B12, folic acid, excluding hyperparathyroidism, and an important forgotten issue is the aluminum toxicity. It shouldn't be an issue if our water treatment unit is adequately removing aluminum from the dialysate. In resistant cases, we should resort lastly to bone marrow aspirate and biopsy and check for bone marrow fibrosis and other causes. This is a quick resume of the erythropoiesis stimulating agents, starting from the very beginning by the epoetin alpha, epoetin beta, epoetin omega. These are the first generation, the second generation, the epoetin beta and darbepoetin alpha, the third generation, epoetin delta, the erythropoietin stimulating, receptor stimulating, the epoetin zeta and theta. To conclude, resistance to erythropoiesis stimulating treatment can increase the risk of negative outcomes in patients with chronic kidney disease. Considering the weak evidence on the efficacy of either adjuvant drug therapies, reversing or controlling the potential causes of resistance seems to be the best strategy so far. Thank you.
We thank Dr. Maher Asaad for this elegant presentation. We'll open discussion now with him. Any question, please?